Well, welcome everyone. I'd like to introduce Dr. Sue Barlow. A little bit of background about Sue. She joined the University of Lynchburg in 2018. She comes to us with a PhD in biochemistry from the University of Kentucky, but she's going to be speaking about her other doctorate, the doctorate of physical therapy, that she got at the University of Tennessee and work she's been doing with that recently. Sue has been recognized with awards for her teaching and her scholarship, and this focus is evident, this focus on effective teaching as well as scholarship within her field is evident and reflected in professional research. Sue's recent publications include posters and presentations papers on pedagogy and effective practices in teaching in graduate physical therapy programs, including peer teaching, experiential learning, and capstone experiences. But she also maintains an active research program in her discipline, which is focused on wrist injuries and wrist weight-bearing tolerance, and that's what she's going to be presenting to us today. It's her work on investigating wrist stability. So with that, I will turn the floor over to Dr. Sue Barlow. Tell us more about wrist stability.
Today's talk, I'm going to tell you about one of my research interests on investigating wrist stability. I truly believe that pain-free functional use of the hand requires a stable wrist. I know this because on November the 27th in 2012, I went to bed at my normal time, and I woke up on the basement floor with amazing pain coming from my left wrist. Apparently, I'd been sleepwalking and I fell down the basement steps. I proceeded to have my wrist x-rayed, and you can see a picture. This is the actual x-ray of my wrist. And, two bones in your forearm. First is the radius, that's the thumb side bone. The other is the ulna, and the x-ray showed that I'd broken both of these bones. Because of the fractures that I sustained in my wrist, I wore a cast for 10 weeks. And after the cast was removed, the mobilization really worked to heal the fractures in my two bones. However, I still had pain with any kind of functional use of my left hand. This was a big problem at the time because I was working as a physical therapist in an inpatient rehab facility, and I required the use of my hand to support my patients. My caseload consisted of patients post-stroke and brain injury. They required a lot of my assistance, and I was unable to hold on to the gait belt to provide safety support. So because of this, I was referred to a hand surgeon, and the hand surgeon didn't do any clinical tests on my wrist. He simply ordered an MRI, and the MRI revealed that I had a damaged triangular fibrocartilage complex, and it was this that was causing the pain in my hand. For those who don't know, the triangular fibrocartilage complex, or TFCC, is one of the major shock absorbers and stability producing ligaments in your wrist. So I went back to the hand surgeon with this diagnosis, and the hand surgeon proceeded to try a cortisone injection to see if that would help with the problem. Cortisone injection didn't really help with my pain, so I went back to the hand surgeon, and the hand surgeon said, okay, cortisone injection didn't help, casting didn't help, this is our standard conservative treatment. Since this didn't work, then we needed surgery. So I reluctantly signed up for surgery the following month, but I was kind of desperate. I didn't know what else to do, so I started doing PubMed searches to see if there was anything else available in the primary literature that would help with my wrist problem. Absolutely nothing was published at this time, and out of sheer desperation, I Googled it and came across a commercially available brace that was supposed to heal my problem in 12 weeks. So I had no evidence that this brace would work, nothing in the primary literature, but I bought the brace, 25 bucks off of Amazon, and wore it for 12 weeks. In 12 weeks, I had full, pain-free, functional use of my hand. I'm a research person. I thought this product saved me from surgery. There are surely other individuals out there that would benefit from knowing about this. I contacted the inventor of the brace, first via email, and then a phone call, and this led to a very productive research collaboration. In today's talk, I'd like to tell you about 3 different research topics that came out of this collaboration. The first part of the talk, I'll tell you about the identification of an objective quantitative test to determine the amount of weight-bearing tolerance that a person could put through their wrist. Based on this test, I was able to determine normative values for wrist weight bearing in individuals between 18 and 65 years of age. And I also identified factors that would predict wrist weight bearing tolerance overall in adults. Second part of my talk, I'm going to tell you about the diagnostic accuracy of this simple test. And this is work that's currently in progress. And then finally, I'll tell you about using the simple weight-bearing test to monitor wrist rehabilitation. So to start with, I'm going to start with the objective quantitative test. The research question is, what are the normal limits of human wrist weight-bearing tolerance? Absolutely nothing known about this in the literature. And this is really important because a lot of times individuals encounter wrist injury and there's absolutely no way to determine whether or not their wrist is stable. And this wrist weight-bearing test, in order to answer this question, we had a sample of convenience, 465 healthy adults between the ages of 18 and 65. These individuals did not have a past medical history of any kind of wrist fracture. They also did not have current wrist pain, and they had the ability to sign informed consent. Yeah, like I said, this was a sample of convenience, but these individuals were recruited from all over the world. A little bit about the subject demographics for this population. As you can see here in this pie chart, shown in the orange, approximately 56% of the subjects were female, approximately 44% were male. Okay, so about equal numbers of males and females in this population. As far as the age ranges for these individuals, that's shown in this pie chart. What you can see here is approximately 10-year age ranges, and there's equal proportion of the majority of the age ranges represented. Okay, so we have a good population of males and females. We also have a good population as far as age ranges is concerned. And one last demographic that I'd like to show you is the height of the individuals. And here you can see on the y-axis is height in inches. The average height of the subjects in this population was approximately 67 inches, and the range of heights varied from 77 inches all the way down to 59 inches. So we have 465 healthy adults, equal numbers males, females, equal representation of age groups between 18 and 65, and an average height of 67 inches. So moving on to answer the question, we have a study design with these 465 healthy adults that I just introduced to you. And we had them perform something that we call the wrist weight-bearing test. Okay, the wrist weight-bearing test is really simple. It's something that can be done in any clinic or any household, really. All you need is a non-digital scale. Okay, you simply ask the subject to place the palm of their hand in the middle of a non-digital scale with the third finger pointing toward 12 o'clock. You also have to ensure that the elbow is fully straightened and that the shoulder is approximately over the hand. Next, you ask the subject to apply as much weight through their wrist onto the scale as they can tolerate. And for this wrist weight-bearing test, they did 3 wrist weight-bearing tests with the right hand and 3 wrist weight-bearing tests with their left hand, and an average of these 3 values was obtained. So the first question that we had is there any difference in wrist weight-bearing tolerance from right to left. To answer this, we just plotted the data on a simple scatter plot that's shown in this slide. Here you can see the right risk weight-bearing tolerance in pounds is on the y-axis, and the left-hand risk weight-bearing tolerance in pounds is on the x-axis. Each of these blue dots represents one of the 465 subjects, and the scatter plot shows that it's a relatively straight line. And when you do the statistical analysis using a Pearson product moment correlation, you can see the R squared turned out to be 0.94. It's quite a good R squared. And these results are statistically significant to less than 0.001. So from this data, we conclude that there is no difference between right and left risk weight-bearing tolerance for each individual. So the next question is there a difference in risk weight-bearing tolerance between gender? And the answer to that is shown here on this slide, where again we have risk weight-bearing tolerance in pounds on the y-axis, and the genders, female is yellow, orange, males are blue, and the average risk weight-bearing tolerance for females in this subject population is approximately 62 pounds. For males, risk weight-bearing tolerance average is approximately 98 pounds. When you do a simple t-test on this difference, we can see a visible difference, but this is statistically significant to less than p less than 0.001. And you can clearly see that the males in this subject population have a much higher risk weight-bearing tolerance than females. So from this information, we conclude that risk weight-bearing tolerance does indeed vary with gender, males having a higher weight-bearing tolerance than females. So the next question is there a change in risk weight-bearing tolerance due to age? And to answer this question, we took the data and did a statistical analysis using simple ANOVA, looking at mean risk weight bearing on the y-axis again in pounds, and the age category, 10-year age categories that I introduced previously on the x-axis. Again, we're sticking with orange as female, and males are represented by the blue line. You can see, starting with males, in the 18 to 24-year-old age category, there's not much of a change between this category, maybe a slight decrease going down to 35 to 44 years of age. No statistically significant difference here. However, there's a sharp decline once the individual reaches the 45 to 54-year-old age category, and this difference is statistically significant, less than p.001. And again, the 55 to 64-year-old age category, there's again another drop. Looking at the females, kind of a similar situation, 18 to 24-year-old age category, mean risk weight bearing approximately 65 pounds, no real change with age, up until you get to about the 45 to 54-year-old age category, and again, another sharp drop with 55 to 64. And this difference is statistically significant from these earlier age categories. So from this data, you can conclude that there's really no change in risk weight bearing for males or females before the age of 44 years of age. However, once the individual reaches the 45 to 54 and 55 to 64-year-old age category, there's a decrease in overall risk weight bearing tolerance. So the next question was, does risk weight bearing tolerance vary with the person's height? And a lot of information on this slide. To answer this question, I did an ANCOVA analysis. Take it nice and easy and look at the fact that here on the y-axis we have risk weight bearing in pounds. Okay, the blue are the males, orange are the females in the population, and over here on the right-hand side of the slide we have the different age categories that I've introduced previously. On the x-axis here, for the males and the females, we have
the subject's height in inches. Okay, just looking at this globally, really broadly, you can clearly see that the average height of all the males in the different age categories was a little bit more than the average height of all the females. And this would be expected in a normal population. So the other thing that you can see, just looking at the males and the females overall, for the most part, there's a positive trend to the line in most of the age categories, indicating that there is indeed an increase in weight-bearing tolerance as the individual gets taller. Okay. So from this information, we're concluding that yes, indeed, risk weight-bearing tolerance does vary with height, and the taller the person is, the larger their risk weight-bearing capacity is. This slide is an easier way to look at all that data that I just showed you. Again, it came from the ANCOVA analysis of the results, and this is what we are calling the normative values for risk weight-bearing. On the y-axis, you have risk weight-bearing, adjusted means listed in pounds. Orange, still female, blue are males, and these are each of the different age categories that I introduced previously. As you can see, overall, females have a lower risk weight-bearing tolerance across all age categories when adjusted for height, and males have a higher risk weight-bearing tolerance than females across ages as adjusted for height. And this is really important information because it means that if I went to the hand surgeon tomorrow with a problem, I can't tell you my age, but I would be in a category, or let's say that I am way down here, they would expect my wrist weight-bearing tolerance to be about 52 pounds. That would be normal. Okay? So this is now, we now have a quantitative measure that someone should be able to apply how much pressure through their hand. Just useful information for adults between the ages of 18 and 65. The other thing that I did with the data is I ran a multi-linear regression analysis, and the results of that model are shown in this slide, where this regression analysis allows us to estimate the person's risk weight-bearing tolerance using this equation. What you have here is, this is a constant. You have the category for gender. Okay, if the person was male, you insert a 0 there. If they're female, it becomes a 1. That makes sense because it would be about 20 pounds less for females. Their height in inches, okay, substitute that number there. 1 if in this category, so it's going to be 13 less if you're in the 55 to 64-year-old age category, or approximately 6.6 less if you're in the 45 to 54-year-old age category. Okay, if you have information about your subject or patient and you simply plug in the numbers, you can relatively reasonably estimate their approximate risk weight-bearing category. And this model has an adjusted R-squared of approximately 37%. And what that means is that risk weight-bearing tolerance, the total risk weight-bearing tolerance, 37% of your ability to bear weight through your wrist is due to your gender, your age, and your height. And this is important to me, or interesting to me, because that means there's 63% out there that we know absolutely nothing about. So this is an area for future research. Okay, so far I've introduced you to the risk weight-bearing test. Simple, objective, quantitative test. Told you about some normative values that were identified and predictive factors of age, gender, and height. Next part of the talk, I'd like to tell you a little bit about the diagnostic accuracy of this test, specifically for TFCC, or triangular fibrocartilage complex problems. Owner-sided wrist pain is actually a black box clinically. So owner means pinky-sided wrist pain overall, and you can see this individual's holding this side of his hand. Why it's considered clinically a black box is because there's so many possibilities that can cause the pain. Okay, one possibility would be a fracture. All right, another possibility would be some sort of cardiovascular injury. Another possibility is a muscle issue or really tendonitis. There's a lot of tendons in that area. And finally, it could be due to the multiple numbers of cartilage and ligaments that are involved in the wrist. In 2021, there was a nice manuscript published by Yang et al. That demonstrated that 40% of individuals that he examined with ulnar-sided wrist pain were due to a TFCC, or triangular fibrocartilage complex injury. The other thing that was noted by Yang et al. In this manuscript is the fact that there aren't very many good clinical tests to diagnose a TFCC injury. Okay, the tests have very low numbers that are able to pull out a test sensitivity, which means the ability to identify a true positive result, and they have very low values or percentages for identifying a true negative, or the specificity of the test. So he concluded that more clinical tests were needed to be able to diagnose a TFCC injury. And since I know a lot of people don't have an anatomy background, maybe here, maybe not, I'm not sure. But triangular fibrocartilage complex, I've been talking about that. That's the problem that I had earlier, abbreviated TFCC. What you see here is an X-ray of someone's right hand with the palm facing you. Okay, the TFCC, what I'm going to do is look, I'm going to zoom in to this area right here. Okay, you remember there's your radius, thumb side, ulna, pinky side. And what you're going to see now is my artistic rendition of the TFCC. Okay, looking at this, so here's your radius, thumb side bone, here's your ulna, pinky side bone. Have things with different colors. The first part of the TFCC is the actual cartilage. Okay, the actual cartilage exists on top of the ulna, and it is a major shock absorber for the wrist. Another part, it's a complex, so there's also a few ligaments to consider. Shown here in blue are the radial-ulnar ligaments, and their job in life is to simply stabilize this distal radial-ulnar joint here in blue. And there's one more important piece, and that's up here. These are the ulnocarpal ligaments shown in green, and their job is to help connect the carpal bones, two I've listed here, with the ulna. Okay, so this complex in total is really important for both shock absorption and stabilization of the wrist. Okay, so when I talk next about a TFCC injury, it could be an injury to the cartilage or any of these ligaments. So our question was, the research question is, can the wrist weight-bearing test be used to diagnose a TFCC injury? And to answer this question, we had 41 subjects with an MRI-confirmed TFCC injury, either cartilaginous or ligamentous. Okay. These individuals were recruited from social media posts, okay, and they were able to sign informed consent with us. The study design was to take these 41 individuals and subject them to something that we call the TFCC weight-bearing test. And this is just a slight modification on the original wrist weight-bearing test. Specifically, you have the individual perform with their unaffected hand the wrist weight-bearing test as I've described previously. Fully straighten the elbow, wrist, as much pressure as you can put through that wrist. Okay, that's the unaffected hand. And then you have the individual perform the same test with the affected hand, and you get values. Next, this is the modification. Whether it's the affected hand or the unaffected hand, it doesn't much matter, but you brace the wrist, okay? This is a picture of the braced wrist using the brace that's commercially available. Okay, this is a picture of a braced wrist just using standard athletic tape. Take a piece of athletic tape, cut it in half, and then you put it just in front of the major wrist bone on the ulna, and then just before the major wrist bone. There's really no difference between these two techniques. Okay, the next part is you simply repeat the wrist weight bearing test with the affected hand that's been braced. Okay, so a couple of different things. We're looking at unaffected, we're looking at affected, and then we're looking at affected braced. And the question is, does this test work to detect a TFCC injury? You can see that the results are here. Wrist weight bearing in pounds on the y-axis, unaffected, wrist weight bearing affected versus the affected brace. And again, these are using those 41 individuals with a confirmed TFCC tear. You can see that the average wrist weight bearing tolerance of the unaffected, these individuals, is approximately 78 pounds, and there's a significant decrease in the affected. And this decrease is statistically significant to less than 0.001. But more importantly, we can also determine something called an effect size. And the effect size, the larger the effect size, the more clinically relevant the results are. A large effect size is greater than 0.8. And you can see the effect size that you get here from the simple weight bearing test is 1.5. So very clinically relevant results. In addition, if you take the affected wrist and then you brace it, you can see an increase in wrist weight bearing tolerance. Okay. This increase is, again, statistically significant with, again, a very large effect size of 1.2. So going forward, a positive test is considered a decrease in wrist weight bearing that actually increases when the affected upper extremity has been braced. And I can tell you, clinical experience and the trial was done, that if you take the unaffected wrist and you brace it, you see no difference in wrist weight bearing. So moving forward, we needed to identify that this TFCC weight bearing test could indeed differentiate TFCC injury from other kinds of wrist injuries. There's lots of possibilities. And the social media posts, we were able to identify 45 different individuals who had ulnar-sided wrist pain. Okay, the risk condition, if they were symptomatic, 41 had the TFCC injury, and then 4 others had other possibilities. And it would be much better for the data, and we'll talk about that a little bit later on, that if I had more individuals that didn't have a TFCC injury, but that is the work in progress. We are still actively trying to recruit these individuals. So what we did is, for the study design, we took the 45 individuals with the confirmed diagnosis, and then we subjected them to the TFCC weight-bearing test, which is weight-bearing, unaffected, and affected, brace the affected, and then repeat the test braced. And our question was, is there any difference between using this wrist weight-bearing test to predict a TFCC injury compared to MRI as a reference standard? The answer to that, or one part of the answer to that, is shown here, where on the y-axis you're looking at the number observed of whether it was a negative test or a positive test. Shown in here are the negative test results if an MRI was used. And shown here are the negative test results by the TFCC weight-bearing test. And if the test was positive via MRI, versus TFCC weight-bearing test, positive. And I can tell you that there's no difference, no statistically significant difference between using MRI or using the TFCC weight-bearing tolerance test, since a chi-square analysis produces a p-value of 0.334. And this is fairly significant, since MRIs are really expensive. Not everybody has access to MRIs. So this is a simple test test that someone could use to determine the presence or absence of a TFCC tear with relative consistency compared to MRI. Another for anyone used to looking at sensitivity and specificity analysis. Here you have a simple 2x2 table where the MRI results, if it's a TFCC tear versus no TFCC tear, this is the reference standard, or the TFCC weight-bearing test, the test was positive or negative. What you can see here is that the TFCC weight-bearing test was able to identify 36 individuals out of the total of 41 who actually had an MRI done. This indicates a sensitivity of this test of 88%. Okay, that's very good clinically. However, you can see here the specificity would be determined as a true negative right here. Unfortunately, there's only 4 individuals who were negative for the TFCC tear, and this is where we're recruiting more individuals because it would be great to say that this test was very specific. There's no other clinical test available that is highly specific for TFCC tears. The 2 that currently exist have about 50% sensitivity. So getting this number up higher is where we're looking to go. So far, told you about this wrist weight bearing test, told you a little bit about the diagnostic accuracy of this test, and this again is work that's in progress. Next and last part of the talk is going to be using this test to monitor wrist rehabilitation. This was done via a case study. So we recruited a 45-year-old male, and he had ulnar-sided wrist pain following a handstand. This was confirmed by an MRI, and his conservative treatment of casting followed by cortisone injection had failed. So he was another individual who was scheduled for surgery to repair the problem. The first thing that we did was we did a standard TFCC weight-bearing test to see if we could identify the presence of the TFCC injury using this test. And those are shown here, where you have wrist weight bearing in pounds on the y-axis. Again, you've seen this is the unaffected upper extremity weight bearing value of approximately 80 pounds. If you test the affected or the TFCC injured side, decreased to about 45, 46 pounds. Again, if you brace, in this particular case, the brace that was used is a commercially available brace. You can see an increase of this individual's weight-bearing tolerance to about 68 pounds. Okay, so from this, we conclude that we can use this test clinically with an individual to determine the presence of a TFCC injury. In addition to the TFCC weight-bearing test, we also had this person fill out an outcome measure, and this outcome measure is known as the Disabilities of Arm, Shoulder, and Hand, or DASH for short. So it's the DASH outcome measure. Okay, this is a clinically reliable and valid test looking at upper extremity disability, and it's a 30-item questionnaire where on this test, if your score is a 0, you have no disability, but if you score 100, you have maximum disability. The subject in this case study scored a 40. Okay, so he wasn't very functional, about 40% functional, okay, given that 0 is no disability. What we proceeded to do is have the individual wear the commercially available brace during all waking hours, and we followed the course of his progress as far as wrist weight bearing tolerance is concerned over the next 12 weeks using the TFCC weight bearing test. You can see the results of that here, where we have wrist weight bearing tolerance on the y-axis and week number on the x, with this is time 0, week 0 at the start of the study, wearing the brace, about 68 pounds total wrist weight bearing tolerance. No real change until about 4 weeks, and then you see an increase in wrist weight bearing tolerance, and this increase continues up until 12 weeks. Okay, all these numbers are generated using the commercially available brace, but I can tell you that after 12 weeks, the individual had wrist weight-bearing tolerance equal to his unaffected hand with or without the brace and was fully pain-free. So looking at it another way, you can look at the change in this person's functional ability using the TFCC weight-bearing test. Time 0 without the brace, he started at 46 pounds. In 12 weeks, he was able to tolerate 80 pounds of pressure through his hand. And 1 year later, still normal compared to his contralateral side. Using the DASH outcome measure, at time 0, he scored 40. 12 weeks later, 0, no disability whatsoever. 1 year later, still 0. Okay, so from this information, we conclude that this commercially available brace is something that can be used by individuals to help a TFCC tear even after commercial management has failed. So, hopefully you've gotten this simple quantitative test, wrist weight bearing test, a little bit about its diagnostic accuracy, more to come, as well as using this simple test to monitor wrist rehabilitation. As far as future research is concerned, definitely we are trying to acquire more data to finish the diagnostic accuracy study. It would be great to have individuals who didn't present with a TFCC injuries confirmed by MRI to be able to show a high specificity for this test. Clinical experiments or just working with people clinically, it does seem to be a very specific test, but that remains to be determined scientifically. The other thing that I'm in progress in doing is generating a case series. So I've demonstrated a case study, which is an N of 1, but it would be great to have a number of individuals, say 2 or 3, and we have the individuals that we're currently monitoring through wrist rehabilitation using the commercially available brace. The last thing that's work in progress is looking at normative adolescent weight bearing values, okay, because adolescents often experience sports injuries that have to do with wrist weight bearing, and there's absolutely no information in the literature about weight bearing tolerance through wrists in adolescents. And I know you've heard me say we this entire presentation because I have collaborators that make me able to do this work. This is Wendy Medeiros. She is the inventor of, it's actually called the wrist widget. It's the commercially available brace that's specific for TFCC tears. She is an OT, certified hand therapist, retired certified hand therapist. It's been great to collaborate with. She resides in Hawaii. And the other collaborator that I have is Jan Steven Schultz. Jan is in South Africa. He's currently a master's student in South Africa. He helps with data collection. Between the two of them, and with all their world travels, we were able to recruit 465 individuals from all across the world, and they've done the data collection. As far as future research studies are concerned, they are the data collecting people, and I helped design the research study and do the statistics and write it up. But I definitely couldn't do any of this work without them. Thank you very much for your time, and I'll take any questions. Anybody? Jeff?
Sue, I'm sorry I was late.
Oh, that's okay.
I teach till 11:30. So if you answered this, I love how you did a case study and you moved into a case series, very logical progression. The next step may be an experimental study. In your work, is there a potential intervention that you could use also to alleviate this?
Intervention for
To
TFCC
lower the clinical condition you're treating, the TFCC?
Yeah, so the actual intervention is just wearing of the brace. So
Oh,
yeah.
that's it.
Mhm,
Okay.
yeah, that's it. So what happens is, there was sort of a story in the beginning with personal experience for me, that's how this project actually started, is I broke my wrist and ended up with a TFCC injury, and there's absolutely nothing that anyone can do, or until I started doing this work, that would help it aside from surgery. So I was signed up for surgery, and I found this commercially available brace, and it saved me from surgery. But it hadn't been published, there was absolutely no information in the literature. So typical management, or it's called conservative treatment for TSCC injury, is casting, followed by cortisone injection. If that doesn't work, the individual, up until about 4 years ago, went to surgery. Well, that's what we're working on. Does that make sense?
Yeah, absolutely.
Okay. Do you have a question?
I think you might have answered it, but I was gonna ask, did they have any, like rehab, like strengthening, range of motion, anything like that? It was just wearing the brace?
Absolutely, yeah. So the cool thing about the brace is that, and that's one thing that you can see, is as soon as you wear the brace, your weight-bearing tolerance goes up. So you actually become quite a bit more functional, and being able to use your hand by itself increases your ability, as you know. I mean, it increases strength, increases everything, yes.
Another question, how much does that brace cost?
$25 on Amazon. Actually, the price is down. If you're really picky about your color, it's gonna cost $45. But for a basic black brace, which I'm good with basic black, it's like $19.99. Really straightforward. And you don't even need the brace. With athletic tape, you can get the same result. The key is to monitor using the weight-bearing test. If the weight-bearing test works for you, then chances are good that the brace or athletic tape is going to work for you too. That's what the test is doing. Any other questions, Jamie?
I'm going to do that thing where you ask a two-part question. First, I'm going to ask about the test that you designed and validated. Could you tell me a bit more about the body position? Because it was outside of the picture, like was it a kneel, was it a plank? And then you were focused on 18 to 65, talking about adolescents. Would the body position or balance issues be why you didn't look at the older age brackets or a geriatric population?
Great questions. So in thinking about it, I'll start with the first one. The body position actually doesn't matter. So if you had a low-lying table, you can put the scale right there, and then as long as the most important thing is that your shoulder is over your wrist and your elbow is fully straight. And then you just put as much pressure. Having done the test, I didn't qualify for the study because I had a TSCC injury, but having done the test, it's remarkably consistent. You can only put so much pressure through your wrist. Why we chose not to go above the age of 65 is it appears that wrist weight-bearing tolerance is negatively affected by bone density as well. That's another ongoing project that I didn't talk about. So we're having people with DEXA scans do wrist weight-bearing. And I think it'd be pretty cool to see if you can use the wrist weight-bearing test to predict bone density issues, right? I mean, that's a whole other area. But that's why we didn't go above 65, just because of the bone density. And we definitely did see, and recruitment, overall individuals were able to be recruited through coffee shops and churches and schools. So just in that patient population. And the risk weight bearing for kids, I actually have the data. The only thing that we're missing from the data is the height of the individuals. And this is data that was available through another source that they had the kids do a risk weight bearing test in addition to all kinds of other tests. So that'll happen pretty soon. Is there another question?
Yeah, it's just a fascinating topic, by the way.
Yeah.
With the positive weight because of somebody's height, does that have something to do with the length of the arms? Like the more of a weight bearing with the arm being in the same position? And then also piggybacking off what she said as far as the body position on the scale, does weight of the individual have, like if they are a heavier person, does that differentiate? And I know you found the median, but I'm just curious.
Mm-hmm. Yeah, so we thought about looking at weight, but honestly it was hard enough to get 465 individuals to participate just with their age.
Sure.
So we didn't look at at weight. I can tell you that my friend Wendy, the clinical OT, has used this test a lot clinically, and she doesn't think that there's any correlation with the individual's weight. It might actually have to, I'm thinking it might have to do with muscle mass personally, but I don't know about weight. Okay, as far as, you had the other question was?
The height and
the
by
height.
taller person's length of arms, maybe.
Yeah, I'm not sure if it's length of arms or just body mass, size, increased, I think about increased bone density again coming through with the person's height. We really don't know. And like I said, there are other things that are involved in risk weight bearing tolerance in addition to the things that I've chosen. But height, again, that was Wendy's clinical experience that came through recognizing that, yeah, the taller a person is, it looks like the more they're able to bear. That makes sense with the male-female correlation too, because males are taller and there's more weight bearing. I think it really has, one thing would be interesting to look at would be BMI, as well as I think the bone density is going to be a big part of it as well.
Thank you.
Yeah, sure. Yeah, Tom?
Is the test in your diagnostic study, was the test administrator blinded from the MRI results?
So there's a lot of, so MRI was used as a reference standard, by the way. So, and just saying that, I know you know what I mean, but so the gold standard for detecting a TOCC injury is going to be an arthroscopy. Okay, definitely did not have, and an MRI. MRA as well will be even better than an MRI. We used an MRI only because it was available with these individuals who so shouldn't be close. So the person did so they submitted their MRI through a form, a Google form, a link, essentially. That wasn't looked at by the person administering the task. The person administering the task was Jan, and he did that virtually, so making sure that the arm was in the correct position and that sort of stuff. So then it becomes my job to look at the MRI results with the wrist weight bearing test. Does that answer your question?
Yep.
So they're using MRI. It's a reference test. MRI by itself is about 85 to 90% sensitive for a TOCC injury, but that's where we are right now. And even just demonstrating that, I think, is clinically relevant. Big savings. Any other questions? I'm glad you understood the words. Great. Okay,
So-
Jeff?
Who's most likely to get this injury? Is it a workplace-tied injury? Is it a traumatic injury? Is there an industry where this may even be more impactful as a diagnostic tool?
As far as industry is concerned, so how do you get the injury? My injury occurred on a FUSH injury, fallen outstretched hand, okay, a broken radius and ulna concomitant TOCC injury. You can have any kind of traumatic injury, so an individual doing a handstand. You can have also repetitive injury, which turns out to be kind of a thinning of the cartilage itself, and that's degenerative in nature. So really those two things. Whether or not it's symptomatic, individuals, as they increase in age, have increased tears in the TOCC, just from degenerative use, but they may or may not be symptomatic. And that's one thing, is people at the age of 50. So I don't know, really anybody that uses their hands a whole lot. Like as a physical therapist, that was my problem, is I couldn't put weight through my hand to support my patients. Right? I mean, anytime you use your hands in that way, I mean, very limited in, picking up anything, pronation and supination is going to be effective with the individual. Any kind of weight, it's all involved. So any industry that uses big things that come to mind are gymnasts, right? Tennis players, even basketball players have the support, and the athletes kind of, it's a large athlete. That's why we're interested in looking at the adolescent weight bearing arms as well, just for diagnosis and also monitoring of the injury time. Does that answer?
Yeah, thank you, very good.
You're welcome. Any other questions? Okay, well, thank you for your time.
Very good.